And then this is our clinical case 1B. 54-year-old man, healthcare worker, no medical problems, presented with fevers, cough, and shortness of breath. His symptoms onset began in April of 2020. So again, we're in the peak of the surge in the region. His SARS-CoV-2 RT-PCR is positive on admission with CT value of 32, and he rapidly improves and is discharged home on hospital day 5.
And so this example, similar to the previous example, has two patients that present with very similar CT values. I think they were both 32. And so that value with very different outcomes, a patient who was discharged and a patient who ultimately sadly expired. And so what's important to realize is, again, the patient, depending on where they present, that CT value may be similar, may be different. And so the patient that expired presented in the later portion of their disease state where they were beginning to experience their hyperimmune response that Dr. Gendlina described on her earlier clinical slide. Whereas the other patient also may have been presenting earlier in their symptomatology and may go through a phase of COVID that is more similar to those that will recover. And so that CT value similarity does not necessarily seem to indicate whether a patient will survive or won't survive. To that end, a lot of the early kinetic data, because of the fact that the CT values we were getting in patients were a single time point, we couldn't really establish what the viral kinetics were. But this past year, the NBA was actually testing their players daily. And what we were able to do was those players that did ultimately become positive, and since we were monitoring every single day, we could begin to get those multiple time points in those patients. And what that allowed us to do to graph here was at the time point 0, days from lowest CT, at time point 0 was the day they had their lowest CT value on the RT-PCR, or the most virus present in a sample. And so what we see is that there is a rapid incline and then a more progressive, a slowly progressive decline in the virus as the body begins to clear the virus. And so the question becomes then, if the major concern here is who's going to have a negative outcome with this virus, is can we establish some cutoff? And so when we were seeing many more patients with poor outcomes pre the vaccination era, and sadly in the vaccination era to those that have not been vaccinated, the question became, can we use a cutoff point to identify who will have a negative outcome? And so what we found was that while there may be statistically significant differences. So when you're dealing with the large amounts of patients we were dealing with in the beginning of the COVID pandemic, we were able to identify and power studies to show a difference. But the point that I want to make on this slide is that there's significant overlap between those with a good outcome and a bad outcome. And so creating any form of cutoff becomes really difficult in trying to distinguish between an individual that will have a good or a poor outcome. And this is some of that data that actually we had that did show a statistically significant difference. But one of the things to point out is that there are a number of platforms available for SARS-CoV-2 or respiratory testing, and they don't necessarily have the same CT values either. They may be slightly different from one another. And so grouping in the laboratory throughout the pandemic, there have been shortages of all manner of items. And so we have taken on multiple platforms. And so what is a CT value on one platform versus a CT value on another platform may not be directly comparable with one another. And so the second question with these cases that we'd really like to ask is, okay, we may not be able to distinguish who will have a positive or a negative outcome, but can we distinguish whether or not the virus that they carry is actually viable? Can they infect someone else? And so studies that related to culture, a very crude measure of infectivity, did just that. They took all of their samples and their CT values, and they tried to culture the virus. And what they found was, while generally, yes, there was a greater proportion of samples that were culturable at the lower CT values, right? So 38 out of 44 in about the 25 range. At the higher range here, probably about 37 down to 5 out of 60 were culturable. But the point here also is that there were still 5 patients in this range that had infectious virus at an elevated CT And so using a cutoff, again, a crude cutoff to say this person is no longer infectious, this person is infectious, could be slightly problematic since there is still a proportion of individuals that will be infectious at those later CT values.
Okay, so with that, let's go into case 2. So we're talking about 70-year-old woman who presented from home. She came to ED with generalized weakness, vomiting, weight loss, and decreased appetite. And we're talking about mid-September of 2020. So we're about to crest our second wave that's characterized, or we're about to start our second wave that's characterized, of course, by the Alpha variant. So she has no known COVID-19 exposures, but some turned out to be asymptomatic positive. Her initial SARS-CoV-2 RT-PCR is negative, with repeat testing performed on hospital day 10 was positive with CT value of 36.3, and this is our standard nasopharyngeal sampling. Patient is continuing to have worsening respiratory status with hypoxemic respiratory failure requiring non-invasive support. Imaging, it was possibly developing pneumonia. Patient ultimately expires due to other medical complication, and postmortem tracheal sampling for SARS-CoV-2 RT-PCR is now positive at CT value of 19.4. So this gets us to a favorite expression from our real estate colleagues, location, location, location. So location matters. If you can see from the picture on the left, our initial recommendations and our practices and our guidance